For sure. Okay, Sean, you are co-host now.
All right. Hi, everyone. I'm Sean. I'm from Emory. I've got a fun case for us to talk through today. I'm one of the PGY3 residents here, soon to be PGY4, I guess. So it's great meeting everybody.
Thank you, Sean. That was amazing. Yeah, everyone, we are really happy to have another specialty Neuro VMR here today. I think you are gonna take the role of facilitator, so I'm not gonna steal the mic more from you. Go ahead.
Yeah, we have an amazing case presenter, Dr. Sean Thompson and Dr. Andres DeLeon will be our main discussants and Velgi as a co-discussant. And Dr. Andres DeLeon is an assistant professor from Emory University and mainly in neuromuscular. And Dr. Andrew DeLeon, do you have anything that you're interested most in neurology, or what makes you exciting about the neurology?
I like all of neurology. I know that sounds like a very PC question, PC answer, but it's true. I do have an interest in neuromuscular medicine. I think it's like where I get to be more specific about localization sometimes, and I get to do nerve conduction studies, electromyographies, which I enjoy doing because it gives me I don't for my so it's like feedback for my suspicions before I get that. Yeah, I love this localizing, which is what like about
I think the audio is breaking up a
CNS
little bit.
oh,
Yeah,
CNS
so
or PNS. Should I,
yeah, it might be the headphones. Yeah,
can you hear me better now?
yeah.
Okay, but now I cannot hear anyone. So, um, okay,
Can you
yeah.
hear
So,
me?
did I cut off too soon? Do you want me to repeat that, or you're good?
Yeah, it's better to repeat because
Okay.
you can like most of the time. So
Um, Yeah, so essentially what I like is the part of localizing. And then within neurology, neuromuscular medicine gives you a lot of that, but many areas of neurology you'll get to do that in one way or another. So that's what I like about neurology, localizing.
yeah, we are excited and thank you so much for joining for today, for taking time and contributing to our clinical problem solver. So, all right, we are all excited and I think we are good to go ahead. We'll start with the chief complaints of the case. Sean, please go ahead.
Of course, the chief complaint is oh, numbness in a right-handed 14-year-old male. Okay, so all of this takes place during this year, 2025. It started in early January, just a few days after New Year's. This young man was playing basketball, and he remembers, going up to shoot, and he started getting some mild neck pain. It was more kind of bothering him over a couple of days. So we went to his PCP. His PCP gave him some Flexeril. I mean, it really seemed to help him. It pretty much went away, but then middle of January, he started getting these flu-like symptoms, like sore throat, coughing, sneezing, fevers for about a week. And during that week, he got a lot more of that neck pain kind of returning, mostly on the right side of the neck. Then, after those symptoms went away, a week later or so, toward the end of January, he noticed that the fingertips of the right hand started having tingling and a bit of numbness when he was trying to touch things. His Flexeril had run out by that point, so he tried Motrin. It didn't really help with the pain, so he just kind of didn't do much for it. But throughout the months of February and March, he noticed that the numbness was getting a lot more noticeable and that it was moving proximally up the arm, like past the wrist, climbing up the forearm. He was still able to play basketball quite often, at least 2 times a week, but he noted that in a couple of games, if he really overextended himself, that he would get a flare of pain that was like shooting and achy in that neck. And all he had to do was rest for 20 minutes and it would kind of subside. But It was getting more and more bothersome to him. His mom at this point was kind of chiding him, saying that he's playing too much PlayStation and he just needs to stop playing it because of bad posture and it'll all go away. And, they just kept going on like that for a couple of months. He noted a little bit of headache developing, but no numbness up in the face or the head. By April of this year, he felt that pretty much the entirety of his right arm was feeling numb, up to the shoulder and connecting now to the pain in the neck. He felt like sometimes it might be weak, but he didn't have any specific weakness. He wasn't dropping things. His handwriting didn't change. It just sometimes felt off. And end of April, April 29th, is when he presented to the ED, and that's where I met him. Some other things, there was no trauma at any point. He has never had any symptoms like this before. I might have said he's right hand dominant. He has no trouble speaking, swallowing, handwriting, typing, or other tasks with that hand, no dropping silverware. And he's had no bowel or bladder changes. And we'll stop there for our first aliquot.
Oh, such a rich history. So, Vili and Dr. Andrews, what would you think first for these kind of patient presenting mainly with the sensory problems, and what localization would you make?
Yeah, thank you, A. Thank you, Sean. I think when it comes to numbness in a young patient that seems to be localized to the upper right extremity, well, numbness is, sensory. So I'm thinking about, it's an ascending track, thinking about from the periphery, about the peripheral nerves going all the way to the plexus. And then the plexus can go to the spine, and the spine can go all the way up to the, cortex of the brain. I think the neck pain makes me think that this is more peripheral. Also the fact that this is, with Dr. De Leon, a neuromuscular specialist. But, other things, the fact that it started in the fingertips in the fingertips of the fingers, and has been ascending, is also one of the things that I think about when it comes to like neuropathy. The fact that it's sensory rather than purely muscle strength type of things also make me think about most likely something on the peripheral nerves. The fact that it worsens when playing basketball makes me think about maybe movements like stretching or extending the arm. When Sean mentioned that, the first thing that came to mind was the possibility of plexopathy just because of the compression in this part of the neck and arm. And the first thing that came to mind was also like Hirayama disease. I think we had a case a while ago that, is usually when people do some type of movement, extending, I think raising the arm kind of compresses the plexus because of an extra bone there, if I remember correctly. But either way, the fact that it has this having ascending makes me think, could this be something in the plexus that is slowly progressing? Could this be something in all the nerves that is, like a multiple neuropathy? So yeah, I think that's, and then less likely something, I guess, on the cervical spine. But I think, of course, the exam is going to be very key to make us localize exactly what muscles and then what nerves are affected. So I'll pass the mic to you, Dr. De Leon. What are your thoughts?
Yeah, that was an excellent approach to this. So far, this very rich history, as I said. Um, One thing that I would say about numbness, and I don't think that's an issue here, but the one thing you always have to sort of like ascertain when patients use the word numbness is exactly what do they mean by numbness. I've certainly have seen when patients say, "Well, my hand is numb," and when you ask them more about that, it turns out that actually their hand is weak instead of numb. Now, I don't think that's the case here because Sean gave a very detailed history. But if you only had that chief complaint of numbness coming from the patient's mouth, because it's a word that people will use, you want to like ascertain, okay, is it really a sensory symptom, or are they using numbness to mean weakness? So that's just like one more thing that has nothing to do with localization or anything like that, but just with sort of like the practice of medicine, trying to convey, like try to understand what the patients mean by their explanation of their symptoms, and then getting into as Vale said, yeah, you want to think about in this case a peripheral nerve problem, and not just it's me, but it does sound like that, like it is like something localized in the peripheral nervous system. Um, and then you want to also try to determine whether this is a territory of one peripheral nerve, one dermatome, or more than one nerve or more than one dermatome. If you're thinking about something in the peripheral nerve, and where when you have someone who has numbness of the entire arm, but you say in the fingertips, and then it went more proximally, it certainly overlaps different territories. Either you don't have a single peripheral nerve that can account for that, and you don't have a single dermatome that can account for that. So it's a good thought to think about the plexus. Um, and I don't know if that's the disease you were referring to, but so Hirayama disease is a disease that affects mostly the motor neurons, the anterior horn cell. Usually, the one that's the motor neurons that correspond to the C7, C8, and T1. So these patients will present mostly with painless atrophy in the C7 to T1, mostly C8 myotomes. That is mostly weakness. But yeah, it does happen in young men. It's very chronic. It happens over months to years. And then they can have some sensory deficits with that if the disease affects the spinal cord, like descending tracts or ascending tracts there. But for the most part, it's a motor disease. It's pretty much a localized form of motor neuron disease. Um, I don't know if you're referring mostly to like thoracic outlet syndrome, where you can have a plexopathy. And then in that case, thoracic outlet syndrome is a certainly overdiagnosed condition. People tend to use that term to refer to many different symptoms, but in reality, the purely neurogenic or true neurogenic thoracic outlet syndrome is a plexopathy of the lower trunk of the brachial plexus. And that could be it wouldn't involve the entire arm, but then going back to this part of communicating with the patient to see what they mean, it is often that I see that even when I have a certain diagnosis, I know what nerve is affected. The patient's numbness will sometimes extend what you expect the numbness to be in. That can happen certainly the more proximal you go. But even in such a common complaint or such a common disease such as carpal tunnel syndrome, which is a median neuropathy at the wrist, you would expect only these fingertips to be affected. But many of you will hear or have heard that the symptoms that the patients describe or the numbness will sort of like go beyond that. I don't think we'll have a really good explanation for that. So I would take it with a grain of salt to see whether there is something that is really truly involving all the sensory fibers of the arm. It can be, but then you think about the plexus, like Vale correctly assumed it was at the plexus. Um, and then if you go more proximally, you want to think, okay, is this not peripheral but rather central? You want to think about something in the spinal cord. Uh, but then you want to see what type of like sensory symptoms the patient has, what kind of sensory deficits to see if you want to localize this to the spinal thalamic tract, to the dorsal column, or if you keep going up, you can get to the contralateral thalamus and then the contralateral parietal lobe. So that's what I would start, given the progression from fingertips to maybe forearm and then arm, and then being isolated to the arm, it makes me think less about the CNS. I would expect that a CNS lesion uh, would affect the leg as well, would involve the face as well, but it's not entirely excluded here.
Yeah, it's such a great discussion, Dr. DeLeon and Valley. Sean, to clarify for the history, is the pain and numbness just happening in one side or is that both side?
Yeah, it is mostly the right side of the neck and the right arm, though he wonders sometimes if the left shoulder feels it just a little bit too, but he's not entirely sure about it.
So Dr. DeLeon and Value, what would be your another discussions regarding if it's more on one side or with bilateral?
Yeah, that's a great question. I guess when it comes to like bilateral symptoms, I often think about, that like the cape distribution, which usually I think localizes more to the cervical spine, like something compressing. I guess because when it comes to neuropathy, I think I would expect if both arms are affected, maybe the legs also to be affected, like the type of, axonal neuropathy type of picture. Um, so yeah, I think that would make a peripheral cause less likely for me, if it was truly bilateral and not as it seems on the history right now that it's more unilateral. I don't know if you have anything else to add, Dr. De Leon.
Yeah, I agree with your thoughts. Once you heard it could be bilateral, then you thought about spinal cord, a syrinx in the spinal cord could certainly account for this once you have bilateral symptoms, but you can have a syrinx that for some reason starts to affect one side first. We're still pretty early in the stage of this disease. It seems like it's been for how long has he had these symptoms, Sean? Like, is it
About
like a
4
couple of weeks?
months. 4
Oh,
months at
4
this
months.
point. Yeah. Slowly progressive over January to April.
And these are sort of like progressive symptoms. He's worsening as time goes on.
Correct. Yes.
Okay. Um,
Right.
no, you can.
Yeah, so I think our history is mostly covered. And if we don't have much like past medical allergies, in terms of like physical examinations, how would you focus on what kind of like examinations in neurological examinations to get your differential diagnosis?
Yeah, I think the peripheral system is so tricky to me to remember, the roots and the nerves and the muscles that those innervate. But of course, I would like, to focus on that, to rule out all types of sensory involvement to see if it's like fine touch, pinprick, vibration, um, to see the strength of the muscles as well. So I guess to determine if there's a specific dermatome, if it's like different myotones affected. I think, and I guess maybe I don't know the importance of doing reflexes in this case, to maybe sync the possibility of something central going on here. I would love to learn from you, Dr. De Leon, about your approach to the peripheral.
Yeah, I was waiting for you to mention reflexes. I'm glad you did because I think they're quite important here. Um, it will be one of the things, unfortunately, we have the capability to test a reflex for every single myotome. But when it comes to the arm, you have pretty much in C5 and C6, both covered by the biceps and brachioradialis, biceps in more C5, but they're both 5 and 6. And then triceps, you have, C7 mostly with a little bit of C8. You don't have a good C5 reflex, you can certainly find cases in with patients who have profound hyperreflexia in whom you can get a pectoralis and deltoid reflex, but those are usually when they're pathological. In this case, you're thinking peripheral nervous system. You want to see what's absent and what being absent would be indicative of a certain localization. So certainly you have an absent deltoid or pectoral reflex. That's normal. But if you were to have an absent C5 reflex, like a biceps reflex or C6, and you start to localize to that particular root, I often in every patient pretty much I check a finger flexor reflex. I don't know if you're familiar with that one, but essentially you take the patient's hand and you tap their fingers here, and then it helps mostly when it's brisk. Like I usually look for it when I'm suspecting a cervical myelopathy, which is still within the differential here. But that's one that gives me the C81 sort of like localization level. So you pretty much have all the roots when it comes to the cervical spine uh, covered in a way by reflexes. In someone who's this young, I would expect these reflexes to be 2+, I would say 2+ brisk. Like, like young people will have brisk reflexes. So anything that is absent here, it strongly points to pathology at that root level in terms of reflexes. And then, as you mentioned before you got to the reflexes, trying to like ascertain which of these, now talking about sensory, which of these myotomes dermatomes is affected, then it also helps you with that localization, especially if you're thinking about a plexopathy, you want to see what part of the plexus is affected, then you want to think about that. One thing that I was thinking also is just because you brought up the diagnosis of thoracic outlet syndrome. Um, Being a lower trunk plexopathy, you can have, or the the roots that go to the CAT1 will be primarily affected, so the weakness was mostly in the hand, but the numbness will be in the medial hand, but also in the medial forearm and even the medial arm. So that distribution will tell you there's something going on with the lower trunk, as opposed to, let's say, an upper trunk plexopathy where you have mostly uh, C5 and C6 type of like sensory deficits, and you have more like apparently Victor Wembanyama has thoracic outlet syndrome. Um, and you will have like abduction weakness. So you have to like try to like see what's weak and what's numb on exam, and that will tell you what part of the plexus may be affected or which nerve root will be affected. And when you put that with the reflexes, that's how you get closer to your localization. Um, Before the exam, I would like to know whether there's any past medical history or any family history. I'd like to know certainly family history. I can tell you why later.
Yeah, Sean, please go ahead with the remaining history.
Of course, we got it all for you. One other thing I'll mention when we were talking about unilateral versus bilateral, oftentimes when you have unilateral deficits, the side without deficits in overcompensating for the deficits for the other side sometimes develop pain and so forth and trying to compensate. So also keep that in mind. So medical history, essentially nothing. He's had no surgeries, has just seasonal allergies. He's only taking, the ibuprofen and Tylenol right now, no other, prescribed medications other than the Flexeril in January. He lives with his family, his mom, dad. He has one dog, has no cats, has not been playing with stray cats in the street or anything like that. Because he's 14. Also, I'll talk about birth and development. He had a pretty uncomplicated pregnancy, was born at term, vaginal delivery, no shoulder dystocia or anything exciting like that. In early childhood, he hit all of his milestones. As far as travel, he was born in India, moved to the US around, I think, 1 or 2 years old, and then has traveled back and forth, just to visit family, but nothing in the past year. Family history, pretty much no neurologic issues, nobody that lost mobility, even if it was unexplained, nobody with issues like him. Review of systems, at least the pertinent things, no respiratory issues, no gastrointestinal issues, including constipation, diarrhea, incontinence, genitourinary, no incontinence, no retention. MSK, just the neck pain that we already mentioned, hasn't fallen. Neurological, he did talk a little bit more about his headaches. Specifically, he mentioned them being bitemporal, feeling like a squeezing band. They were worse when he kind of bears down, if he coughs, if he screams while he's having a headache, or if he hears a very loud noise. Okay. Otherwise, no changes to speech, swallow, altered consciousness, vision changes, hearing changes, anything like that. And anything else you want to hear about with his history before we pause?
Yeah, please go ahead, Valley and Dr. De Leon. Is there anything you want to recap about the history?
Not that I can think about right now, honestly.
I had missed the headache part. The headache start along with these symptoms as well, and
Yeah, he noticed it maybe end of February, early March, so not at the beginning of everything, but he didn't really have significant headaches before.
and this has never happened before to him. He's
No,
never had excess of weakness
first
in any
13
other limb.
years,
Yeah,
nothing.
but
Yeah.
he's never had weakness in the other arm that improved on its own, or one of the legs or anything like that.
Not that he can recall, and nor can his mom.
Yeah.
Um,
He-
yeah, go ahead.
Yeah, and then how about is his neck pain? Is it more like a muscle type of
It
like sprain, or does he have neuropathic type of features?
Good question. It's achy. It kind of shoots. It's most of the time it's pretty mild, like maybe a 1 or a 2. At the time I met him, it was a 1. But when it flares up, like when he's playing basketball a lot more, it can get up to a 7 or an 8. But then when he rests, it goes away in about 20 minutes.
Vale, I don't want to put you on the spot, but with the headache, along with everything else we've talked, is there any way that you can sort of like connect like the things we've talked about to a headache in a young patient?
Um, Honestly, I'm not sure, but I was thinking about maybe like the vasculature of the neck area being involved, like as we see maybe with something like Still syndrome or the subclavian being involved with something compressing there and also compressing the plexus, that could lead to headaches and pain. Um, I also know that there are some types of migraines that can present with focality, but I believe even though migraines, you know, the symptoms that usually like tingling, numbness, that they can be part of like maybe the aura type of presentation, usually tend to be longer that maybe we see with something like seizures. I don't think it could be this long and this progressive. So yeah, besides that, I'm not really sure. What should I be thinking about?
No, I don't, there's one thing I'm thinking about, but, I want just to highlight what your thought process. I think it's great that you're able to use the temporality of the symptom to sort of like get to the etiology. You're thinking, we haven't really localized this fully, right? We're still, thinking it through before we get to the exam, which I hope will help. But even before that, we have certain possible areas of localization, and then you're also like thinking about, based on this localization, what could this be? So the temporality of this is very important. If you have continuous sensory symptoms for 4 months, you say, well, this is unlikely to be a migraine. Migraine is something that comes and goes. But if you're thinking, you have a headache, then you have to think about what kind of headache syndromes would account for this. Um, since we did discuss the possibility of this being a syrinx in the spinal cord, the syrinx in the spinal cord can be associated with a Chiari malformation, which could in turn cause headaches that worsen with Valsalva, such as when he's bending over, and then although it's technically two different lesions, there's a common sort of like association. It's pretty much part of the syndrome of Chiari to have a syrinx at the cervical level.
Thank you for that teaching. I had no idea.
Yeah.
Yeah, I don't expect you to. That's you're doing a great job so far.
Thank you, Dr. Delio. This is such a rich discussions about the localizations and all the associated symptoms. Sean, do you want to go ahead with the clinical examinations findings?
Of course. And to answer some questions in the chat, no weight loss, no fevers, no night sweats. I'll say we're in the Southeast US. I don't know if I should say the state for privacy reasons, but
It's okay.
yeah. Going now to the physical exam. In general exam, no acute distress, sitting up, respiratory, everything was clear. Cardiac, everything was clear. For HEENT, there was no neck swelling, no like particularly like sore or tight muscles on the neck, no cervical adenopathy or stiffness. And then looking at the skin, there was really no skin changes on that right upper extremity, no loss of hair, no redness, nothing of that nature. Mentation was pretty unremarkable throughout. He's alert oriented, language is totally fluent, pretty much as you would expect for a neurodevelopmentally unremarkable 14-year-old boy. Cranial nerves, I will highlight that there was no facial droop and there was no deficit to light touch bilaterally on the face. Otherwise, all of the other cranial nerves fairly unremarkable. I'll also say no ptosis, no meiosis, no anhydrosis, anything like that. For motor, I did a very detailed motor exam. So not only just, shoulder, elbow flexion extension, wrist flexion extension, but finger abduction, thumb, APB abduction, finger extension and flexion. All of those were 5 out of 5s throughout. Lower extremity, similar thing, both hip flexion, extension, abduction, adduction, all of the knee, ankles, as well as inversion, eversion, EHL, all of that 5 out of 5 strength, as far as I could force him against me. I will also add there was no appreciable atrophy and no fasciculations. Going to sensory now. Light touch throughout the right upper extremity decreased. He graded it maybe like 15, 20% of compared to the left upper extremity. For sharps, it is decreased throughout the right upper extremity. He can really barely feel even the pressure of the pin. Going further, it's anterior, posterior, lateral, medial, pretty much every aspect of the arm, all throughout the palm and the dorsal side, as well as all of the fingers. Going up to the shoulder, it is decreased. Up on the right side of the neck, it is decreased pretty much to the angle of the jaw. And it is also decreased going down his chest, going down the side of his torso, pretty much down to about 3 centimeters below the umbilicus. And then moving over to the midline on both anterior and posterior of his torso, it goes pretty much to the midline, this Sharp's numbness. So he kind of buried the lead on that one. Vibration totally absent throughout the right upper extremity fingers as well as the elbows. Temperature absent in the right upper extremity. Proprioception absent right upper extremity. And of course, all of these no deficits in the other extremity or in either lower extremity. Those are totally appropriate. All right. Coordination. No significant dysmetria on finger, nose, heel to shin, rapid alternating movements, with his eyes open at least. Reflexes in the bicep of the right upper extremity was 1+, tricep 1+, brachioradialis I was unable to elicit. And then throughout his left upper, left lower, and the right lower, everything was 2+. Plantar stimulation was down bilaterally, down going toes, I mean, and then the Hoffmans were negative in both upper extremities. His gait, narrow base, symmetric strides, good foot clearance, really unremarkable. No Romberg with his eyes closed. So in summary, subjective weakness in the right upper extremity, but not really against my resistance. And then, of course, the sensory exam, not just involving the parts that we had mentioned, but also going down the torso a good ways. We can, let's see, I think pause there for discussion.
Yeah. Sorry, you just want to clarify the sharp. This is all decreased to sharp to pinprick.
To pinprick.
The right arm.
Yeah, and when I went back with light touch, it was also decreased.
Okay. Do you test temperature? Maybe hard.
Temperature, he really couldn't appreciate it throughout the right arm.
Okay.
Yeah.
Yeah, so Dr. Dillian, with such an interesting and sensory examinations and the findings, how would you think, regarding to get your differential diagnosis and all with the tracks going in the spinal cords, like not just with pain and temperature, or with the vibration and proprioceptions, with all of these tracks and symptoms, how would you do your differentials and how are you trying to get your localization?
I have one question, sorry, Sean. Was it decreased only on the right side of the abdomen and chest?
Correct. The left side was totally unaffected on my exam.
Okay, thank you. So yeah, I think I can start with some thoughts. I'm really overwhelmed with this exam because it's for sure something that we were not expecting, I think. So yeah, I think it's safe to say that we're beyond the cervical spine probably, which was what we were not thinking really. I think, so yeah, as A mentioned, it seems like there are a lot of types of sensory involvement, the dorsal column type of um, tract is involved, but also the spinothalamic type of fibers. And then we also have, the thoracic dermatomes involved until, sorry, did I freeze?
You're okay. Uh-oh. We can see and hear you, so I don't know if your side is frozen.
Yeah, we were able to hear you until you asked whether you froze, but you were going okay. I think she's out.
Maybe can't hear us.
Um,
Um,
Okay, in that case, Dr. DeLeon, you can go ahead with your
Yeah.
differential.
So I share her Valid's sort of like issues we're having with the exam, and as I mentioned earlier, I didn't know about this case, but sometimes with the sensory exam, you have to take a few things with a grain of salt. It's very hard sometimes to use that on its own to localize something fully, but we have to do our best here. So I was thinking it could be a syrinx in the cervical cord. Usually with a syrinx, the first tracts that will be affected would be the spinothalamic tract. And then in that case, I would expect pain and temperature to be affected, um, which he does have pain and temperature affected in the right arm. And then to a certain extent, also in the thoracic level, all the way down to T10, I guess, until the umbilicus. So it's a more extensive lesion that I thought, but then what I can't quite, explain with at least with that possibility is why the dorsal column type of information, such as vibration and joint position sense, like proprioception, are affected to the point that he cannot even, um, you know, feel any vibration in the arm. I think that's a bit unusual. And then usually with a syrinx, you want to see also similar symptoms on the other arm. So I don't know what to make of that, but I still think it has to be something related to spinal cord, and then with the headache being present, the spinal cord affecting the roots and the spinal thalamic tract tracts with the reflexes being low. It argues against this being an open-motor neuron type of issue. So it's still the spinal cord, but not the long tract, so rather the spinal thalamic tract only, and then probably the roots to those muscles, to the biceps, to the brachioradialis and triceps that have low reflexes. Yeah, someone asked about multiple levels being affected, support syringomyelia differential. Yeah, that's exactly right. That's what I'm thinking. By syrinx, I mean a syringomyelia, um, which can be associated with a Chiari malformation, and that could explain the headaches that worsen with the Valsalva. And just trying to connect everything in the same syndrome, I don't want to give him two diseases. Certainly, it would be very unusual for a 14-year-old to start having two different diseases that start at the same time. So you want to find something that explains the headaches, explains the numbness, and hopefully will explain the sensory exam. That's what my mind is going to. Of course, people can have as many diseases as they want, and we'll hear more. But I think this is just at least one syndrome, maybe more than one lesion.
Thank you, Dr. DeLeon, for your rich discussion. Vali, do you want to also share your thoughts? You just got frozen before.
Yeah, sorry about that. No, I think thank you for your explanation, Dr. Leon. The only question I had was Sean, when you mentioned the cranial nerve exam, it really caught my attention that you put such an emphasis on facial droop. Um, is there like a reason that you were thinking about that may be affected?
Yeah, I think one is if he had had facial sensory loss, that helps me kind of like change up my localization because that means I'm at least high up, into the brainstem, for example. And then the other is thinking, could our sympathetic system be affected, like with ptosis, meiosis, and hydrosis? Kind of a Horner's, am I thinking about a lesion that at least goes out that far to affect the sympathetic chain, potentially compressive or something else? So that's why I mentioned those things.
Thank you.
In regarding the different shares and the localizations, we got like a lot of cover with history and examinations. Dr. Dillians and Valley, how would you approach these patients in terms of like investigations and any other like further studies? Would you also try to like nerve condition study and EMG to rule out other differences, or you don't think like you would just go ahead with the imagings? What kind of thoughts would you do?
I'm not sure if I can, categorically say that, But I think I'll be interested to see if there's indeed, nerve damage. So a nerve conduction study may be helpful. But I think after listening to Dr. De Leon's reasoning to spinal imaging may be really helpful. I guess the question that I have for you, Dr. De Leon, is how far down the spine would you go? I know that the thoracic spine is involved. I mean, the thoracic dermatomes are involved, but should we go even lower to the lumbar spine, like do a full spine, or what's kind of like your reasoning to decide that?
Yeah, that's a great question. So always when you're thinking of spinal cord, you're kind of obligated to go at the highest level where can explain the lesion. Let me rephrase that. So that you have something in the thoracic cord, let's say in this case, the arm symptoms wouldn't be explained by that. So you need to have something at least at the cervical cord or higher. That doesn't rule out a lesion that is higher, let's say at the brainstem, but for some reason, for some fascicular sparing, doesn't involve the fibers that go to the cranial nerves and things like that. But you always like obligated to go at the level where you're affected and higher than that. So if this patient had let's say only the patient, let's say a different case, the patient only has paraparesis, let's say gradually progressive paraparesis, yeah, you're gonna think probably the thoracic cord, but you can have a lesion at the cervical level that can somehow spare the fibers that go to the arm and explain weakness in both legs. In this case, I don't think a thoracic lesion although he may have more than one lesion, but a thoracic lesion wouldn't really explain what's going on in the right arm. So I would go at least with the cervical spine. And I just have another question, Sean. Did you mention that at the beginning he had some sort of like viral illness, or am I misremembering that?
He
I just,
did, yeah. Early January, he had flu-like symptoms for about a week.
yeah. Um, yeah, I forgot about that clue. Um, so that's more for like etiology more than localization, but it's certainly something that can be accounted for in the sort of like differential diagnosis. You know why that could be important, Valley?
Like I often think of something like post-inflammatory, like inflammatory post-infectious type of thing. Like I guess you're thinking about amylopathy. Well, amylitis in this case.
Yeah, exactly. If we're thinking spinal cord, you have like a preceding viral illness. You think of post-reactive inflammatory condition. Yusuf mentioned ADEM, which is also something that we think about when someone has a flu and then it's followed by neurological symptoms. It happens in children and usually presents with encephalopathy, but is the M in ADEM stands for myelitis. So it's another good thought. Um, but yeah, that's why that I had that. I have forgot about that flu-like symptom before it started. Um, I assume it has something to do with the presentation. It has nothing to do with it. It was just something that was there chronically, and the sort of like symptoms started, and that depreciated everything. Um, but, you're always trying to connect all the information that you're trying to see, how that fits in with our possibilities here. And there's inflammatory lesions to be considered here. And yeah, to go back to also start with the MRI of the spinal cord at the cervical level.
Sorry, Dr. De Leon, I don't know why, I don't know if your microphone, it keeps like chopping off.
Um, where did I cut?
Oh, no, no. I mean, I think we understand you. It's just a
Okay,
little like you just,
yeah.
the volume keeps like going down and then coming back. I don't know.
Um, let me see. All right.
Right. So shall we go ahead with the imaging and lab tests? Sean, how does your team approach?
Perfect. So We'll go with the lab work first. ESR was 22, just barely above normal. CRP 0.2 normal. CBC and CMP were wholly unremarkable. His B12 was 422, folate 14.4. A1C was 5.3, TSH 1.26. So all, to summarize, fairly unremarkable things. There were some other things that were in process that just kind of got lost on the way. Now to imaging, what we got was MRI brain, C and T spine, all with and without contrast. What it showed was a number one, a brainstem elongation and inferior displacement of the obex downward through the foramen and magnum, including the cerebellar tonsils. And in the spine itself, there was long segments syringomyelia extending from C1 to T9. The fluid dissected predominantly throughout the right side of the cord, but when you look at it, it is probably the largest one I've ever seen, at least on the axial cut. It's in the middle, just slightly to the right, but it definitely involves quite a bit of territory in that central cord. Anyone surprised? Now, something I'll point out is, so if we all remember our classifications of Chiari malformations, the big differentiator Chiari 1 to Chiari 2 is whether we have displacements of the brainstem down through the foramen magnum. Chiari 1 typically not. Chiari 2 definitely you do. Chiari 1 is more just like, the cerebellar tonsils. However, Chiari 1 is more associated with syndromyelia, versus 2 is, more of the myelomeningeocele. And here we have both this downward displacement of the brainstem plus fairly large syndromyelia. So they actually call this Chiari 1.5 because it has those mixed features. It's a pretty rare variant, but here we have one.
Wow, such a great case. And I have never seen that kind of like very extensive syringomyelia. Like I've seen a lot of but not that much extensive. And our like Dr. Dillian got the diagnosis since the beginning, like with the history. So Dr. Dillian and Valley, do you have any recaps regarding this finding and or about like syringomyelias and Chiari 1 formation?
Yeah, for sure. It's something that I need to read on. I have never seen a case, so this is first and amazing to learn from this. Yeah, I think, I was quite on like doing a diagnostic like dissection of what we discussed initially. I think, I mean, the exam was just so important to kind of see that the thoracic part was also involved. Otherwise, I think I was so anchored on thinking about the arm and maybe only going as far as that plexus. And I think, those clues that Dr. De Leon pointed out about the headache and how important that was um, to kind of, make us think about this diagnosis. So thank you. That's for sure something that I need to put on an illness script for these malformations.
Yeah. For all my sort of like being dismissive about the sensory symptoms in a way, being so extensive all the way down to T10. Well, it seems like it does fit with his settings going all the way down to T9, right? Still don't quite understand why vibration and preposition would be affected only in the arm. If you have a large enough serings, yes, it will compress the dorsal columns, but in that case, also like do that compression, certainly with such long serings to affect the vibration of your position sense in the legs as well. Uh, but yeah, it's at least that sort of like pain, so like sensation to pain to pinprick being affected on the entire right arm and then on the right half of the chest and then the abdominal down to the umbilicus, which is T10, uh, pretty much fits with Sean's examination.
Yeah, I had thought a lot about that too. Like, why isn't more involved, especially with how extensive it is radiographically? And my way of sleeping at night is that this is, probably a very slowly progressive thing over many years, not even just a couple of months. And so maybe a lot of it had been somehow compensated over time, and then only is it slowly getting unmasked with the symptoms that we have. Because yeah, looking at it, you would have expected left-sided symptoms. You would have expected a lot more weakness and so forth. So yeah.
And I guess a flu-like symptom was probably
totally a red herring there.
Yeah,
Or maybe the
totally.
unmasking,
Yeah.
trigger.
Yeah, who knows? And then someone asked like whether the exam was more normal than we might expect. I think so, but also yes or no. I haven't seen the image myself, but I expect more deficits certainly. But at most searings that I've seen, I haven't seen that profound vibration in your position sense loss because it's in the middle. It's a dilation of the ependymal canal, and the fibers are there are the spinal thalamic fibers. So pain and temperature, more so the dorsal column involvement. So I would expect more deficits, but then with this exam, I don't really expect the vibration in your position sense to be affected in that arm only.
Mhm.
Yeah. Do you have any thoughts about like regarding the treatments or further steps that your teams would do for this patient?
What would you do, Valerie? You get this consult. What's the next step? Who do you call?
Neurosurgery. Um, yeah, I really I'd love to learn from you, Sean. What did you do and your team?
You got it in one. He was still finishing his school exam, so they scheduled an outpatient decompression surgery for probably next week or so, I think. Um, yeah. And then PT and OT in the meantime.
No more basketball for our poor
Just for a little bit. Yeah, let him finish first.
One important thing about this case is like technically it's a spinal, well, not technically, it's in reality a spinal cord problem. But if you look at the exam, he has low reflexes and then and there's really no long track signs which you always want to look for or want to find in someone who has a spinal cord issue. So steerings will fool you in that way because um, they may not affect the sort of like dorsal columns. They may not affect the cortical spinal tract. In fact, they probably affect the cortical spinal tract before they get to the dorsal column.
Mhm.
But they may just affect the spinal thalamic tract, and then in that you only have pain and temperature being affected, and then reflexes maybe being low on that side, but nothing really screaming this is spinal cord, go for it, until you maybe like put everything together. As we, when we practice in neurology, we first try to localize, but then we get this sort of like once we localize, we're thinking it could be here, here, then we think, okay, how did this present over time? Like, did the patient wake up with this, or like yesterday, and he was like this already? Did the patient wake up with something like this 4 months ago? He's been slowly getting worse over time. That's very important to sort of like navigate what the differential diagnosis could be. And also, the third component to that I would add is the demographics. A 14-year-old man with a boy, I guess, with no past medical history, then that sort of like rules many other things out. Um, but yeah, great case. Great case. Thank you, Sean. You didn't
Thanks,
disappoint
everyone.
as usual.
Yeah, thank you, Sean. Belly, do you have any thoughts?
I just wanted to say something about what Dr. Darian just mentioned about how, we can have an exam that may be a little underwhelming for our suspicion. And I remember learning a while back that usually when we have like, not necessarily in this case, but when we have like mixed upper and lower motor neuron signs, we often think about, the worst ALS. Oh, but I think the main reason for that happening is actually cervical myelopathy. And it's just a point to what you mentioned about, how that's very chronic time progression can really fool us when looking for the lower motor neuron signs versus the upper motor neuron signs that we would expect in patients like this.
Yeah, that's a great thought. That we've seen, many patients with ALS, and sometimes that's not an issue because, well, it's not an issue, or rather, not a diagnostic issue, because the patients have bulbar symptoms. So once they get to have bulbar symptoms, you say, well, this cannot be a cervical myelopathy, right? I have to be at the brainstem or above. Um, but some patients may not have them early on, and then you want to think, is there a cervical myelopathy that could explain this? And then that's a good thought that you think about that when you have that combination of upper motor neuron and lower motor neuron symptoms or signs rather.
Yeah. Thank you, Valley and Dr. Leon, for your thoughts. Sean, do you also have any final thoughts to share regarding your case?
Yeah, when I was reading up on my Chiari 1.5s, I found another interesting case where, as we mentioned, our patient gets a headache when he bears down and coughs. There's other patients that will have complete syncopal episodes when they cough, and thought to be, we have the brainstem there, and if you change the pressure and pretty much impact it against bone, maybe you're hitting your pontine reticular formation or something along those lines. So this thought it would thankfully not happen to our patient, but interesting nonetheless for this particular disease.
Yeah, I think there's a Chiari been like 3 and
Mhm.
4, but I've only seen Chiari 1 and 2.
Mhm.
I don't know what I guess the 1.5 here is given by what exactly? Why is it not Chiari 1? Can you explain that to
Yeah,
me?
because the brainstem herniation down through the foramen magnum is usually
Brainstem is,
not seen.
yeah,
Yeah,
not
so
just
not just the
cerebellum.
vermis, but the whole brainstem
Okay,
being herniated as well.
got it. Oh,
Yeah.
interesting. Yeah,
Hmm.
excellent case.
Yeah.
All right.
Thanks,
Thank
everybody.
you all. Thank you, Sean, for your great case, and also Valley and Dr. DeLeon for great discussions. We all have an amazing Carry 1.5 case and with a Surin. So I hope you will all enjoy our case discussions. And I think it's time for us to close out the meeting. So thank you, Dr. De Leon, for your time and discussion. We really appreciate it.
Yeah,
All right.
thank you. Had a great time.
Thank you.
Thank
Thank
you.
you all
This
for
is the
Bye,
joining.
everyone.
It was
Bye.
lovely to meet you and to see
Yeah,
you again.
likewise. Yeah,
All right.
bye.
Thank you all. Bye.
Have a good night.
Have a great night.